What I wanted to talk about today is device therapy for heart failure, stimulating my heart. Um, so there's a lot of different methods to treat heart failure. We've talked about sort of the end-stage heart failure over the last 30 minutes with the total artificial heart. But we have a number of things that are currently available that we should think about for our heart failure patients that involves interventional and electrophysiologic therapy for these patients. First, so I won't talk about will be CRT and His bundle pacing. Obviously, Dr. Razavi will probably have to ask him questions about that and his opinion. Atrial fibrillation as well. Clearly a benefit in mortality with heart failure. Along with that, TEER, so mitral valve end-to-end repair. What I'd like to focus on primarily today is cardiac contractility modulation, as well as baro reflex activation therapy. And these are both FDA-approved devices that we need to think about for those patients who have failed medical therapy. Along with that, I want to briefly touch about pulmonary artery denervation as well as intraatrial shunts, something that you'll hear a lot more about. So obviously, heart failure is projected to increase across the United States. We'll be dealing with over 6 million patients who have heart failure. The mortality and morbidity with heart failure is significant. We have a mortality rate, if you look at 10 years, about 10%. So we're trying to mitigate the progression of heart failure. Over the last 30 or 40 years, we've had sort of an incremental increase in the amount of therapies that we've had for heart failure, starting with preventive therapy for stage A, medical therapy for stage B and C, and we just talked about stage D therapy and stage heart failure, where we'll potentially have novel therapies like the Bivacor, but currently have BADs, inotropes, as well as transplants. Now, looking at that, device therapies may improve symptoms and may actually mitigate this progression towards end-stage heart failure. So if we look at the heart failure patient's journey, you can look at initial insult there, where we start neurohormonal therapy, try to improve the patient's condition. And then after that, some of these patients, a minority of patients may benefit from CRT. But we have a number of patients that may not be candidates and may actually progress to failing medical therapy. And we can see that one of the big red flags is hospital admissions. And when these patients get admitted, their mortality rates increase. And with that, there's a host of patients here who we need new and novel therapies for. So first, we'll talk about cardiac contractility modulation. This is a therapy that's actually embedded in years of history dating back to the late 50s and early 60s. It involves stimulating the ventricle at the absolute refractory period, and the impulse generates 300 to 400 times the output of a typical pacemaker. And what it does is that it augments contraction through a number of different processes. So we look at our pressure volume curves. We can look at the pressure here, and with that stimulation, what we see is an increase in DPTT, and also lusotropic effects that occur in addition to the stimulatory effects that we see. There are several mechanisms of action for CCM, again, 40, 50 years of history. One is it improves calcium sensitivity. Along with that, it can also improve contractility, lusotropy, and actually there's a lot of data to show that it may improve gene profile and actually revert the heart back from its fetal programming to more of an adult programming. Along with that, we see short-term benefits where the contractility improves, and this has been shown by a number of different labs. And then you get gene profile normalization that propagates after that. In addition to that, over time, what you'll see is some degree and overt degrees of reverse remodeling that happens from there. So what's the evidence behind CCM? This came through a number of trials. They all had the fixed trial. In the initial trial, they showed an improvement in exercise capacity. And then in the larger trial, they found an improvement in exercise capacity, increase in VO2, and 6-minute walk. And then what they found was that through these trials, especially the phase 3, that there was a subgroup of patients with an EF of 25 to 45% that really benefited from this therapy, and it was that group that had the absolute largest benefit in this therapy. So if you look at the FIX-HF5 trial, you see that in those patients with an EF of 25 to 45%, these patients improved significantly in their exercise capacity. So based on this, the FDA approved CCM, and we've been using CCM as a therapeutic device for our patients with heart failure who maintain class 3 symptoms despite optimal medical therapy. Now with that, there's also the aspect of neuromodulation with heart failure, and this is something that's actually been studied over the last several decades as well. Through heart failure, you get an increased amount of sympathetic activation, decreased parasympathetic activation, and that leads to all sorts of deleterious effects downstream. And there are a number of different ways that you can actually abrogate this process. One is through vagal nerve stimulation. That's been done in several different methods. But on D there, what you'll see is patients who have baroreceptor stimulation. And this is, again, here, with the activation of, with heart failure, you have a decrease in reflex sensitivity, leading to increased sympathetic output, decreased parasympathetic output. And this device here is implanted. Currently, it's a surgical implant, but there's novel sort of techniques to implant this all by electrophysiology. And here, through reflex activation therapy, you can actually lead to decreased heart rate, decreased remodeling, increased diuresis, and increased vasodilation, leading to absolute improvements in heart failure symptoms. So this was shown to be a benefit in the BeAT-HF trial. And currently, its eligibility is EFs less than 35%. These are patients not eligible for CRT. Along with that, New York Heart Association class 2 or 3, NT-proBNP less than 1,600, and there's really no restriction for atrial fibrillation or flutter. So this sort of summarizes, where we see heart failure as far as those patients who've been maximized on the medical therapy. You can think about baroreflex stimulation for patients who have really bad EFs, CCM therapy, 25 to 45%, and then we also want to think about our other therapies that we talked about here, afibrillation for all of these patients. So one of the things that comes up is heart failure with preserved ejection fraction. If you look at heart failure as a whole, really what's increasing in the United States is heart failure with preserved ejection fraction, by far sort of the growing epidemic in the United States for a number of different reasons: obesity, age, better revascularization techniques. So this is something that has a lot of morbidity associated with, including mortality. So what device therapies are on the horizon for this disease, heart failure with preserved ejection fraction? Maybe the best thing is the Bivacor, who knows? But currently what we have is a heterogeneous disease process in these patients who may be obese and they have exercise intolerance. You have a lot of patients that may have a left atrial myopathy, high left atrial pressures, those patients who have pulmonary vascular disease, as well as those patients who have vascular stiffening. So we have different therapeutics for these different phenotypes of HFpEF. One thing that we're doing right now is the AIM Higher trial, and this is looking at CCM therapy, cardiac contractility modulation, for those patients who have EFs that are on the higher side. So this would be 40 to 60%, seeing if this will benefit HFpEF patients. So this is a trial that's actively enrolling right now. One of the things that's really interesting is the concept of the intraatrial shunt. You remember from medical school, Lutenbacher's, where someone has mitral stenosis, has an atrial septal defect, and these patients do better. So behind that concept, or kind of trailing that concept, they came up with intraatrial septal devices, and this is a big hot field in heart failure. And the first device that was shown up here is the Corvia device. We've implanted multiple number of these devices, and the reduced lap HF2 trial, this was published in Lancet a couple of years ago. Sanjeev Shah from Northwestern, the PI for this, they showed that these patients actually really didn't benefit, but there was a responder group that did benefit from this device. More recently, if you guys were at ACC last year, Greg Stone presented the results of the RELIEF-HF trial. This was a different intra-atrial shunt called the V-Wave, and this actually was eye-opening. It showed that the heart failure with preserved ejection fraction patients actually didn't do so well, whereas the heart failure with reduced ejection fraction patients actually improved. So there are a number of different intra-atrial shunt trials that are ongoing, and we're actually involved in the reduced lap trials as well as the RELIEVE trial. And currently what we're looking at is the RESPONDER-HF trial. And these patients are patients who have HFpEF, have a significant exercise limitation, and these patients will be randomized to the intra-atrial shunt. The key thing here is that they cannot have pulmonary vascular disease. So they can't have pulmonary vascular disease. So what they found from all these trials was the presence of pulmonary vascular disease is very bad. So you create a shunt there, and if the RV cannot handle it, these patients are going to do poorly. So now they're trying to streamline this to look at those patients who have HFpEF without pulmonary vascular disease. We've enrolled about 3 patients in this trial, and the ones, and it seems to be working pretty well. Along with that, what about those patients who have HFpEF and pulmonary vascular disease? This is something that's, again, a big hot topic. And one of the things that we've done has been involved in pulmonary artery denervation. This is something that the Chinese brought forth, and there was a trial in Israel that showed its benefit. This is a specific type of ultrasound-based device that was originated from Stanford. An old THI surgical fellow really came up with this while he was at Stanford. And basically, heightened sympathetic stimulation can lead to pulmonary constriction, and it's thought that denervation of this may lead to improvements. So we're involved in the EFS right now, early feasibility study for this novel device. We've done a few of these along with Duke and I think Wisconsin, and so we'll see where this field goes. And this is the trial Gradient Prevail HF2. I think Methodist is also involved in this trial as well. So interesting therapy for HFpEF, and these on the opposite side have pulmonary vascular disease. So I just wanted to end here in the interest of time, and I'll leave it for questions, and thank you for having me.